Yes, ma'am. We are live now, ma'am.
कहाँ चला गया सर?
A very warm welcome to all the esteemed faculty members and
Dr.
delegates
Parag
who have
Biniwale
joined
is
us.
also joined. We can
Yes,
start
ma'am.
with the
Thank you.
program.
This is the AMOGS Emergency Obstetric Committee webinar with the UPCOG Societies of Lucknow, Varanasi and the AMOGS Society of THANE, Navi Mumbai, Gadhinglaj and Udgir. This is the 59th episode in this series by convener Dr. Sneha Buyar Madam, who is also the chairperson of the Emergency Obstetric Committee. I welcome all of you officially on this platform. And Sahiti, can we have the inauguration slide, please?
Resting powder is perfect.
Thank you, Sahiti. I would now officially welcome the MOCs, Dr. Pragati Agarwal Madam and Dr. Nutan Agarwal Ma'am also to join me for this session. And I would officially welcome Dr. Sneha Buyar Madam, who is the chairperson of the Emergency Obstetric Committee in AMOGS. She has been the past chairperson of the Breast Health Committee of FOXY. She also holds position in the IMA Maharashtra State in the Mission Pink Health. She has been a recipient of various awards, including the MS Signature Award. We welcome you, ma'am, to officially welcome the delegates and the faculties on this dais today. Sneha, ma'am?
Yes.
Yes, ma'am.
A very good evening to one. A very good evening to all the respected seniors here. My respect and regards to everyone. Especially I pay my regards to Madam Chandravati ji. Madam Pranam. In spite of her poor health, Madam has joined for blessing us. So thank you so much, Madam. And of course, I thank the UPCOG, the patron, Madam Usha Sharma ji, Madam Meera ji, and Madam Chandra ji. I also thank and welcome the guest of honor for today's program, Dr. Manju Shukla ji. Madam is joining in a minute, and of course, Dr. Priti Kumar, our very dear friend, and of course the Vice President-elect Foxy. I welcome all the AMOGS office bearers, especially Dr. Kiran Kurtakoti, the President, AMOGS, Bipin Pandit, the Secretary, Dr. Rajendra Singh Pardesi, immediate past President of AMOGS, and Dr. Madhuri Mendare, the Treasurer. I welcome Dr. Parag Biniwale, who is the ICOG Chairperson and also the National Coordinator for AMOGS. I welcome the entire team of AMOGS as well as UPCOG, and I am very happy to have all the respected faculties here, the chairpersons, panelists, speakers, and of course, to the speakers for today's program. I think Madam Anuradha Khanna has still not joined. Dr. I request you to please, Nutan, I request you to please call Madam Anuradha Khanna ji so that we can have Madam's blessings as well. So to start with, I would like to invite Madam Chandra ji, for blessings. Madam, you're so kind and open-hearted that you always guide us and bless us. So, Madam Chandra, everybody knows as patron of UPCOG, and Madam was the dean of the Tons College as well. She's the Professor Emeritus of Department of Obs Gynae KGM and proprietor director of the Krishna Medical Center. So, without much ado, I would like to have Madam's blessings and, of course, the guidance for all of us. Madam, over to you for your blessings.
Thank you, Sneha, for inviting me for this webinar. It was a really surprise because I wasn't expected to be here today. But my good wishes are to you for all your future endeavors, whatever you're planning, and also your best blessings and best wishes for your webinar for today. And I hope that with Varanasi and Lucknow Society. You'll have a wonderful number of delegates to join you for this wonderful program. Thank you, Sneha. Thank you so much.
Good evening, Changai.
Thank you so much, Madam. Once again, Pranam and thank you. And Madam Manju Shukla ji, welcome, and Pranam, we have already welcomed you. And definitely, I would also like to welcome all the President and Secretaries of Varanasi and Lucknow Societies, Dr. Priti Kumar as President and Dr. Seema Mehrotra as Secretary, and also Varanasi, Dr. Shalini Tandon and Dr. Shuchi Jain as Secretary. And the societies of Maharashtra, I would like to welcome Dr. Pratibha Chauhan as the President of Gadhinglaj, Dr. Mahesh Joshi, President of THANE, and Dr. Nageshwari Nanda as Secretary. From Navi Mumbai, we have Dr. Bindu and Dr. Parurekar. So I welcome all of you and to this program, and I would like to go ahead with the blessings from Madam Manju Shukla ji. So Madam, please bless us and guide us. Over to you. Madam Manju Shukla, all of you know that retired professor of Obs KGM Lucknow and retired professor HOD from CIMSH Lucknow. Of course, she was the president of UPCOG, president of Lucknow Gynae Society, and lots of accolades to her credit. We are very happy and privileged to have you, Madam. Over to you for your blessings.
Thank you, Sneha, and good evening to all. मैं अभी ना लेट हो गई थोड़ा ज्वाइन करने में और चंदा जी गुड इवनिंग कहाँ है पता नहीं चली जो है सबको गुड इवनिंग एंड स्नेहा तुम्हारा वेबिनार should be very successful and so many people have joined till now, so it will be a big success and the topic of interest will be, what is your topic? I am sitting in clinic, so all the best. You can proceed.
Thank you so much, Madam, for your blessings and best wishes.
Best wishes. All the best.
Thank you, Madam. Thank you so much.
Sneha ma'am, I have talked to Dr. Anuradha Khanna ma'am. She is having some eye problems, so she has sent her wishes.
Okay. Thank you so much. Thank you. So let us go ahead and just have, do we see Dr. Kiran Kurtakoti? I think Dr. Parag Biniwale will represent Dr. Kiran Kurtakoti because Dr. Kiran is busy in some emergency. So precious words from our dear friend Dr. Priti Kumar, who is the guest of honor for today's program. Yes, Saiti, Dr. Priti Kumar.
I think Sneha, Parag is joined. Please.
Parag is joined? Okay.
Parag is joined.
Yeah. So let us have the precious words from Dr. Parag Biniwale, who is the ICOG chairperson and the national coordinator for AMOGS.
Thank you, Sneha. Don't waste time in that.
Yes. Please go ahead.
Good evening. I bring greetings from AMOGS, and it's indeed a pleasure to join this webinar as the national coordinator of AMOGS. And I represent Dr. Kiran Kurtakoti, who is the president of AMOGS. Indeed, a pleasure to share virtual dais with the who's who of UPCOG, especially Lucknow, Madam Chandravati, Madam Manju Shukla, and very dear friend Dr. Priti Kumar and everyone from Lucknow. Sneha, I must appreciate your efforts to reach out to different states because maternal mortality is still very high in states like UP, Rajasthan, MP, and Bihar and Jharkhand, and you made all your efforts through your emergency obstetric committee to reach out to these societies and do our bit to reduce maternal mortality. My best wishes for the program, best wishes for the elections which have started today, and a happy learning to everyone. Thank you very much for having me today.
Thank you so much. Thank you, Dr. Parag, for your wonderful insight also to this subject, what we have been trying hard to reduce the maternal and mortality. So may we have the words of wisdom from our dear friend Dr. Priti Kumar, who is the Vice President of FOXI, and what to say about Dr. Priti Kumar. She is a multi-talented personality. She was the chairperson of the
Thank
Safe
you,
Motherhood
Sneha.
Committee.
Thank you.
It's not the official post, yes, but then she has been doing so much of work for women's health all across India, and she has crossed all
Thank
the
you. Thank you. Thank you.
boundaries for that.
Thank you,
So over
Sneha.
to you for your precious words, my
Thank you, Sneha. Uh, I welcome AMOGS virtually here, and I'm happy to see Parag here representing AMOGS, but missing Dr. Rajen Singh sir and also Dr. Kiran. But anyway, welcome to especially Lucknow because we have lot many societies today. And Sneha, I have been observing you. You always take very relevant topics related to maternal health. And today you have taken emergency obstetric care, and you are trying to collaborate and try to find out actually the challenges in different states, what we are facing. So. Uh, your dedication and passion, I think, over years had been tremendous. Your hard work as a committee chair, the breast committee chair, you have done tremendous amount of work. And from a very small society of Yavatmal, it's really commendable, Sneha. I really appreciate and admire you, and I too get a lot of inspiration from you. And today's webinar, I'm sure you have excellent speakers. Smriti is very good, and other speakers are very good. So a lot of learning for the participants who will join. And best wishes to you and everyone who has joined, Monica, especially the election going candidates. Wish you all the best, and you are the best. But definitely, the elections are elections. We have to fight it, and then we have to come out as a winner. So,
Yes.
thank you and best wishes to all of you. And over to you, Sneha, now.
Thank you, ma'am. Thank you for your
Thank you
blessings.
so much, dear. Thank you for your blessings and best wishes. Of course, it means a lot to me. Thank you, dear. Thank you so much. Thank you for gracing the program as well. Thank you. And do we have, I think Dr. Saroj Singh is busy somewhere. She has conveyed her apologies. So we go ahead with the academic session now. So
Hi,
the
Dr.
blessing.
Preeti.
Yes,
Hello,
yeah.
Dr.
So,
Sneha. Bharti here.
yes, Dr. Bharti, I was desperately calling
Hello,
you
Dr.
and
Bharti.
Hello,
Hello,
Dr.
देखो
Bharti.
मेरा पूरा
Welcome.
UPCOG आ गया देखो.
yes.
Good evening, ma'am.
So, yes, my dear, welcome Dr. Bharti Maheshwari, who is the secretary of UPCOG. So, we actually today we are missing Dr. Saroj Singh also, and definitely we were missing you till now, searching for you everywhere. But we welcome you, and yes, everybody knows you so well. It's a UPCOG program. Professor and head Department of Obsgyny, very academic person and a very vibrant personality working in all the aspects of obstetrics and gynecology, candidate for Vice President Foxy from North Zone. We welcome you, dear Bharti, and over to you for your precious words.
So, again, like UPCOG and AMOGS both are together and we are associated for a long time. So, Dr. Preeti is also here and all esteemed stalwarts. So, best wishes and congratulations, Dr. Sneha, to you. And I need blessings of all of participants, esteemed faculties. So, need really blessings of all of you. That because, it is my second attempt. So, always I want that it should be come out, and same for Sneha also. And all of you have given us lots of support and blessing and love in the past also, and we want that should continue. And of course, we will continue with our good academic session as Dr. Sneha has organized with his team. So best wishes, and we want to start the session.
Thank you so much. Thank you, dear Dr. Bharti. Do we have any other guests? Actually, all our guests have, Madam Chandraji had joined, Dr. Bharti, Madam Manju Shukla is here, Dr. Preeti ji is still here, Parag Biniwale, I think you just joined, so I'm informing you. Most of our, guests have joined. Only Meera ji's, I think, sir's, birthday, so that's the reason she was little sad. So she could not join, and she has conveyed her blessings to us also. So thank you so much, and with God's blessings and our respected seniors' blessings, we go ahead with the academic session. I thank you all the dignitaries for gracing this program and all their blessings. I thank and also welcome my conveners, three conveners, my dear friend Dr. Nutan Upadhyay, Dr. Pragati Agrawal from Bareilly, and Dr. Monica Umbadan from Maharashtra. So once again, I welcome and thank all of you. And over to you, dear friends, for the academic session.
Ma'am, I would like to take this opportunity to wish both the dynamic contestants here, Dr. Sneha and Dr. Bharti Maheshwari, all the best. And I think you both are making lots of waves. And I just wish from all my heart that you both are successful in your endeavors. Our wishes and support are there with both of you, ma'am. So 1st August, let's hope it has started with a bang. Lots of wishes to both of you, ma'am. And I sincerely wish to see both of you holding office very soon. My
Thank you.
wishes and best of luck, ma'am.
Thank you, Dr. Nutan. Thank you.
Nutan ma'am, the same wishes for me too.
मोनिका
जी
जी,
मंजू मैडम कुछ कहना
आपको
चाह रहे हैं.
भी
नमस्ते मंजू मैडम.
आपको भी बहुत सारी wishes and hope to see you soon, all of you.
Thank you.
Best wishes from my side also.
Thank you, ma'am.
Lot
Thank
of
you.
Sneha and Dr. Bharti for both
Thank
of
you.
Yes, let the vice presidential elections go successfully, and then of course we have Monica and the governing council member.
Dr. Manju madam want to say something, Sneha
Please,
ji.
please, madam, please.
Ma'am, you need to unmute yourself, please.
Yeah.
बस मैं यही कहने जा रही थी भारती, all the very 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 best.
Thank you madam. Thank you. Thank you so much.
बात तो हो ही गई है, दिन में रिजल्ट आ गया.
जी बिल्कुल जी मैडम.
ठीक है,
जी
चलो
मैडम.
बाय बाय.
Thank you, madam. Thank you for your blessings. Thank you, everybody. Yes.
Okay.
We have very good speakers, Dr. Smriti Agrawal. Yes, please go ahead with the academic session and get on with the program.
I declare that the inauguration is now over, and we will now begin with the first academic talk, which the speaker is Dr. Sangeeta Rai, madam, and she'll be speaking on management of HTP complications. I would like to welcome the chairpersons for this session. Dr. Bindu, madam, is the president of
Dr. Sangeeta Rai joined? Have you confirmed? I could not see. Dr. Sangeeta, did you call her?
Ma'am, I haven't called her, but there are a lot of people without the name, so I exactly cannot understand whether somebody is joined.
No. Do we have Dr. Sangeeta Rai? Otherwise, you call one of you. Dr. Pragati, can you please call her? Just check. Otherwise, we can have Dr. Smriti's talk first.
I don't have her number.
Okay, let me see. Dr. Shalini, it's there on the group. Dr. Shalini Tandon and Dr. Shuchit and I have already welcomed, and I can see Dr. Shalini here.
Yeah, I'm here. Yeah.
Yes,
I
yes,
just
yes,
called
ma'am.
Dr. Sangeeta and confirm where is she. I'm just going to call Dr. Sangeeta Rai.
Please. Should we wait, madam?
Yeah, just give me 1 minute to call her.
Yes,
Sure.
ma'am.
Yeah. So, yeah.
डॉक्टर बिंदु और ये थाने से है या प्रेसिडेंट और सेक्रेटरी डॉक्टर बिंदु एंड
बिंदु नवी मुंबई से.
हाँ सॉरी नवी मुंबई एंड डॉक्टर महेश जोशी थाने.
Mahesh Joshi,
Dr. Mahesh has sent this message. He's in an emergency.
Has he joined?
Mahesh sir is not around, ma'am. He is in the labor room. He's in an emergency.
He is in emergency. He called me also.
अच्छा.
Dr. Sneha. Hello.
Hi, Madhulika. Good evening.
Hi, how are you?
I'm fine, dear. I'm fine.
Yeah.
Nice
I
to see
think
you.
I have joined, but you cannot see me because I am on the way for a meeting.
Okay. No problem, Madhurika. I'm so happy that you are here.
Yeah.
Yeah, and thanks to all of you. You know, this program has been organized so nicely, and all these three conveners have helped me so much because I'm traveling all the time.
I know. You are very
Few
busy.
hours in one city and next few hours in the other city.
Yeah.
Yeah.
But that's nice.
in
Now,
case
at least you are doing webinar.
Yes.
Ma'am, in case it is taking the time for Dr. Sangeeta to join, maybe I can start my talk if you permit.
Yeah. In fact, we were waiting for Dr. Shalini to convey. She said just 1 minute. So, in fact, I had already said that if Dr. Sangeeta is busy, we can go ahead with Dr. Smith's talk. But just let us wait for a. Um,
So, best of luck in advance.
Thank you, my dear. Thank you so much. Keep your support. Please.
Yes, of course.
Yes. Continue your support till 10.
Yeah,
Yes. See, every vote makes a difference. So till
of course.
August 10th,
Yes.
thank you so much, dear. Thank you.
You're,
Yes, Shalini?
Hello, Dr.
hard work.
Sneha.
Yes, tell me.
I have to apologize on behalf of Dr. Sangeeta. Actually, today is an emergency day in BHU and she's stuck in an emergency. So she's
So
saying it
we'll
will
have it
take a long
later on.
time. Yeah, maybe she will not be able to deliver her talk, so we can proceed further with our webinar.
Okay, no
So
problem.
she said to apologize on her behalf.
No need to apologize.
Okay.
You know, madam, we
Okay.
know that we allow obstetrician anytime
Actually,
we can. Madam.
today is a call
In
day
fact,
also
it's our
in
miss.
BHU.
No problem. If she's okay, we'll go ahead with Dr. Smriti.
Yeah, we can proceed further. Yeah.
Ma'am, then I would introduce the chairpersons of the first talk because Shalini madam is there. So I'll introduce her and ask her to chair the second session as well, ma'am, with the
Yeah,
other.
okay.
Yes. Can we just have the slide before? Yeah. Thank you, Saiti. Chairpersons for today's session, Dr. Shalini Tandon madam is the president of the Varanasi OBGYN Society. She is the vice president of the IMA Banaras branch. She is also the secretary of the Club 35 Plus of Varanasi Menopause Society. She has received many awards, including the Foxy Achievers, the Kashi Gaurav, the Nari Shakti, the Kashi Ratan Award, the Aspiring Women's Award, privilege enrollment in the Dainik Jagran Coffee Table Book. She's more than 30 years of private practice experience. We welcome you, ma'am, as a chairperson for this session.
Thank you so much for your kind words.
Our other chairpersons for the session, Dr. Seema Malhotra, ma'am. Can we have the CV slides, please, Saiti? Yeah. She is currently the secretary of the Lucknow OBGYN Society, also the secretary of ISOPAB Lucknow chapter in 21 to 24, the member of Medical Education Committee of Foxy currently, and member of Safe Motherhood Committee Foxy. She is also the executive council of the Indian Menopause Society Lucknow chapter. We welcome you, ma'am, for chairing this session. Our next chairperson, Dr. Ritu Khanna, madam, is director of the Khanna Medical Center and Fertility Clinic at Varanasi. She was the chairperson of the Foxy Food, Drug, Medical, Surgical Equipment Committee from 21 to 24. She is also the secretary of the Society of Fetal Medicine UP chapter and the Central Executive Committee member of Society of Fetal Medicine. We welcome you, ma'am, for chairing this session. And Dr. Yogaraj Chidre, sir, he is the president of the Udgir OBGYN Society. We welcome all of you and ask you to please introduce our speaker, Dr. Smriti Agarwal, madam, for today. Shalini, ma'am. Hello. Shalini, ma'am, can you introduce Smriti, ma'am?
She's there, but I think you can introduce Monica.
Yes, ma'am.
Yeah, please go ahead.
Our speaker, Dr. Smriti Agarwal, madam, today is a professor, head of the department of the RMLIMS Lucknow. She has been awarded the Professor Dhavendra Kumar Young Investigator Award as a gold medalist at KJMU Lucknow. She is also the member of the core group to revise the emergency obstetric curriculum of the Ministry of Health and Family Welfare of 2019, a member of the expert group on formulating guidelines in medical disorders in OBGYN and genital tuberculosis for the Ministry of Health in 2015 with the Government of India. She's the Joint Organizing Secretary of AICOG 2020 at Lucknow, the Joint Secretary of Lucknow OBGYN Society from 20 to 22. She has special interest in fetal medicine and reproductive medicine. She also has a clinical attachment at King's College London in fetal medicine in 2014. We welcome you, ma'am, and it is an honor that you will be speaking today on this platform with us.
Welcome. Welcome.
Thank you so much. Just give me a minute so I can share my slides.
Sure.
Right, ma'am. Are my slides visible?
Yes. Just make it full screen. Yes. Perfect.
Yes,
Thank you
ma'am.
so much. A very good evening to all the dignitaries present in this webinar. It is indeed an honor for me to be present here, and a special thanks to my mentor, Dr. Preeti, who has always supported and helped and loved me in every venture. Today, this webinar, I will be talking on a very important topic on sepsis in pregnancy. So we know that all of us have been working on, decline of maternal mortality rate. And we also know that maternal mortality rate has shown a significant fall from 130, which was there in 2014, and it is already 97 per 1 lakh live birth. And we are slowly inching towards attaining a goal of less than 70 as per the Sustainable Developmental Goals by 2030. For the maternal mortality, the leading causes of death are obstetric hemorrhage, which still constitutes a major chunk, followed by infections, pregnancy-related infections, which constitutes around 12% of causes of maternal mortality. Now, which women actually are more predisposed to develop pregnancy-related infections are the women who are nulliparous, women who have obstetric risk factors like PROM, women who have UTI, recurrent UTIs in pregnancy, who undergo cesarean delivery, women who undergo any kind of an ART procedure, which is so common these days, and multiple gestation. They are found to play some role in increasing the possibility of infections during pregnancy. Now, around more than 50% of the women who ultimately die because of infections usually have some kind of a comorbid conditions, which can be a chronic renal disease, chronic liver disease, congestive heart failure, or maybe any other as well. We are all obstetricians working at several centers. Very often we get a woman who is operated elsewhere, day 3 post-cesarean, who comes to us with shock, with anemia. And on admission, we realize that her blood pressure is very poor, 70 systolic, and usually if she's running high temperature and also a foul-smelling discharge, we know that this is a very common condition which we see in our practice. Now, the question is, does she have sepsis or does she have infection? Is there any difference between these two words, or we can use these words interchangeably? Well, the answer is that infection which leads to life-threatening organ dysfunction, then it is called as sepsis. This infection can happen during pregnancy, during delivery, post-abortion, or postpartum period. Now, when sepsis is associated with hypotension, despite IV fluid resuscitation and leading to cell dysfunction, hypoxia, and cell death, then we say it is septic shock. Now, when we say organ dysfunction, this may involve any particular organ of any system. For example, if we have a central nervous system involvement, it will manifest itself as altered mental status or delirium, which we see often. If the cardiovascular system is involved, it is usually seen as hypotension or myocardial dysfunction. Pulmonary system, it is usually comes out as ARDS. And if a woman has GI system involvement, she will present with paralytic ileus. She can also present with hepatic failure or elevated transaminases. She can also develop oliguria and acute kidney injury, indicating urinary system involvement, or thrombocytopenia, DIC, hematological system, or adrenal dysfunction and increased insulin resistance, leading to high blood sugars. So the idea basically is that any of these organ dysfunctions can be present with infection. And if any organ dysfunction is present, then the patient is said to have sepsis. But we know that medicine is not so simple. A lot of times, fever, which is such a integral part of any kind of an infection, may also be absent. Sometimes a woman may have negative cultures, and sometimes we don't even know why she's developing fever or why she is developing sepsis. A source may not always be identifiable. Sepsis will always remain a clinical condition, and there is no specific test which can be diagnostic so as to say that she has sepsis or she does not have sepsis. In pregnancy, because there are a lot of physiological changes which can happen either in the antenatal period, intrapartum or postpartum period, sometimes it leads to a lot of confusion in our minds as to what we are dealing with. Because pregnancy is a state of modified immune function. Normally also women develop tachycardia, vasodilatation, and increase in respiratory rate. And sometimes these signs may mask early signs of sepsis. So as obstetricians, we have to be more careful to understand that this is a physiological adaptation or she's developing features of infection and sepsis. Now, another problem in pregnancy is that even organ dysfunctions like creatinine, normally we take levels more than 1.2 as abnormal, but for pregnant women, we have to take levels more than 1.02 as abnormal. Similarly, mean arterial pressure in a non-pregnant individual, it has to be kept at 70 millimeter of mercury, but in pregnant women, we are happy to have mean arterial pressure of 65 millimeter of mercury. So these are certain things which we have to keep in our mind whenever we're dealing with a woman who is thought to have infection and who is thought to have sepsis. So can we actually quantify how much sepsis a woman has? Well, there are two quantification scores, which are SOFA scores and quick SOFA score. They don't define sepsis, but what they tell us is that which are the women who need an aggressive therapy. And for this, a very easy bedside tool is a quick SOFA score, where you take 3 clinical criteria, which is systolic blood pressure, respiratory rate, and altered mental status. Now, the ones which I have circled in red have been modified for obstetric women. So if the systolic blood pressure is less than 90, or respiratory rate is more than or equal to 25, or she is in delirium or drowsy, if 2 or more of these criteria are present, then we know that a woman has a positive quick SOFA score, and it should prompt a physician to see what is happening, which organ is involved. So the woman would be in sepsis, and the physician would need to initiate or escalate the therapy. If the patient is, however, admitted in ICU already and she's thought to have sepsis, then we have to take the full SOFA score, which we are all very much aware of. Now, why does the sepsis happen? In obstetric cases, most of the times it can be because of septic abortions or PROM leading to chorionitis. Sometimes recurrent UTIs can also be a cause of sepsis and pyelonephritis. In the postpartum period, the commonest cause of sepsis is endometritis or surgical site infection, whether it is episiotomy or whether it is a cesarean section wound. In non-obstetric cases, UTI, pneumonias, appendicitis can form a major chunk. And in the postpartum period, again, it can be because of the similar causes. Now we have to remember, whenever we are choosing our antibiotics, it is important that we are well aware of which organisms are leading to sepsis. E. coli is the commonest, followed by group B hemolytic streptococcus. Now, whenever we have a woman, there are certain basic principles which we need to follow. First and foremost thing is to correct the perfusion. Then look for the organ dysfunction, whichever the organ system may be involved. So do it systematically, and then you will have an idea how to escalate your therapy. Begin appropriate antimicrobials and send appropriate cultures. So in total, sepsis 6 has to be followed. Now it is termed as sepsis 6 because it helps us to remember that there are 6 things which have to be done. They need not really follow a sequence, but these 6 things should be done whenever a woman with sepsis is admitted under us. Number 1 is we have to administer her high flow oxygen because this woman is already suffering from tissue hypoxia. Take blood cultures, both aerobic and anaerobic, without any delay. But obviously, do not delay the starting of antimicrobials just because you're not able to send the cultures. Administer the broad spectrum antibiotics. Which ones? We'll be talking about them. Measure serum lactate. Serum lactate is a very important surrogate marker because it tells us the level of tissue hypoxia, because lactate levels will rise in our cells and tissues if the women develops features of tissue hypoxia or poor perfusion. And fluid resuscitation is a very, very important step. We should administer 20 to 30 ml per kg. For example, any women, pregnant women, it is important that we give around 1 to 2 liters of crystalloid whenever we think that she is having hypoperfusion. Similarly, fluid resuscitation should be continued if the lactate levels are more than 4 millimoles, because again, it is because of poor perfusion that the tissue hypoxia is happening. Catheterize the women and measure the early urine output. Now, fluid, as I said, fluid therapy should be the most basic step. And the solution which is used is usually Isolite M or Ringer's lactate. In pregnancy, 1 to 2 liters is reasonable and can be safely given. Albumin may be included, or maybe you can delay that once the treatment gets started. However, synthetic colloidal solutions, they should not be used because they can cause more harm than helping her. Now, when we give her fluids 1 to 2 liters, how do we know that the fluid which we have given is enough? That can be done by passive leg raising. You can raise the legs by 30 to 45 degrees. And if that leads to autotransfusion of around, that will lead to autotransfusion of around 300 cc of blood, which is pooled in the lower limbs, and it will result in increase in the cardiac output. So then you know that this woman is, the fluid which you have given is good enough. But obviously, we cannot do this in the 3rd trimester because there the gravid uterus is already going to be pressing on the inferior vena cava. Another thing which we can do is a point of care ultrasound. We all know that we have an ultrasound machine which is available to us. So look at an IVC diameter, which is very easy to see. If you find that the diameter is less than 1.5 centimeter, and with the respiratory cycle, there is some variation in the diameter. So that means that the woman is still fluid deficit. However, if the IVC diameter is more than 2 to 2.5 centimeter and it appears very turgid, that means she's already fluid overloaded. And at that particular juncture, we need to come down to only maintenance therapy and do not give her too much of fluids. Now, collection of samples, it is very important because sterilization of the cultures can happen as soon as the antimicrobials are given. But obviously, again, if we have certain limitations that we are not able to send the cultures immediately, we should not delay the antimicrobials. And the samples which are usually sent are high vaginal swab because, as I just mentioned, the cause of sepsis are usually choriamnitis or endometritis. Midstream urine can also be sent, wound swab if there's surgical site infections, or if there's a respiratory tract infection, then throat swabs, etc. So what antibiotic? When the woman is not so critically ill, then coamoxiclav is the safest antibiotic and the best antibiotic to be given. Or we can also give her cefuroxime, or we can give her cefotaxime and metronidazole. So if the patient is taking well orally, then maybe coamoxiclav and cefuroxime is a good option. If she is not able to take well so much orally, then cefotaxime and metronidazole should be added. If a woman has allergy to penicillin, then clarithromycin or Clinda and Genta should be given. If the patient is critically ill, then we need to step up our antibiotics, and the best would be to give piperacillin tazobactam, or we can also give meropenem and linezolid, or ciprofloxacin and gentamicin, and metronidazole can be added because, again, anaerobic infection is a very important cause of sepsis. Now, how do we define, choose the antibiotics also depends upon whatever the antibiograms of our hospitals are. Now, as I said, serum lactate levels is an extremely important. So the initial lactate level is more than 2 millimoles per liter, then we should measure it after 2 to 4 hours because we expect the levels to come down even further by our fluid therapy. But if after fluid therapy also, the serum lactate levels are more than 4, so then we need to start vasopressors. That means we have not been able to improve the perfusion with the help of fluid alone. Now, after we have done these super 6 steps, it is important that we do a detailed physical examination, trying to identify where the source of sepsis is and stabilize her accordingly. Imaging should be done, especially if there is no response to treatment, or if in any clinical examination, we think that maybe there is a TO abscess or maybe there is collection in the abdominal cavity, pyoperitoneum, or anything, maybe a consolidation. So imagings which can be done like chest X-ray or ultrasound, whatever is available in the emergency. And later on, when the patient is stabilized, then the patient can obviously undergo CT or MRI, whatever the need may be as per the case of whatever the case she has. Now, if the woman has not responded to fluid resuscitation, then there is no point in perfusing her with more fluids because it can lead to pulmonary edema. So that is the point where we need to start her on vasopressors. And the drug of choice should be norepinephrine because it is safe for fetus and it has been found to improve the hypotension in a good number of cases. Our target mean arterial pressure should be 65 millimeter of mercury or above. If the woman is also having a coexistent bradycardia or myocardial dysfunction, then dopamine may be used. Otherwise, norepinephrine will always be the first choice of vasopressor in the women who has septic shock. The use of vasopressin, experience regarding it is very much limited. If the woman still has refractory shock, then we also give hydrocort, which is around 200 milligram per day. So steroids should always be reserved for only those women who do not respond to fluids and vasopressors, and it should not be a first line of management. If the woman is still antenatal and still preterm, then of course we can give dexamethasone or betamethasone, whatever is available for fetal lung maturity. At the same time, since I was mentioning the main problem is tissue hypoxia, we also see whether the woman actually has good enough oxygenation, good enough hemoglobin level. So red cell transfusion should be done if the hemoglobin concentration is less than 7. If the patient has associated DIC, then fresh frozen plasma should be given if she's bleeding. Remember that we should not go after correcting the lab values. We should actually be just looking at the patient as a whole and try to understand whether fresh frozen plasma is needed or not. Similarly, platelets should be transfused if the woman has platelet level less than 10,000, or if it is less than 20,000 and she is at a high risk of bleeding, that is, she is a case of retained products of conception, or she is already in DIC. And if we want to do any kind of an operative intervention, then we have to maintain the platelet count as low, more than 50,000. The other supportive therapies may include mechanical ventilation depending upon her profile. Then we should also try and maintain her blood sugars because these women, they develop insulin resistance when they're in sepsis and their blood sugars may shoot up. A practice of giving bicarbonates to correct the tissue hypoxia or lactic acidosis is not recommended and it should be avoided. Give the women prophylactic DVT prophylaxis by low molecular weight heparin or unfractionated heparin. But if the patient already has DIC, then heparin should be avoided. Stress ulcer prophylaxis in the form of PPI should be given, and patient should be allowed oral or enteral feeding, whatever if her bowel movements are good. Now, just because a woman has sepsis or septic shock, that does not mean that we need to deliver, because very often we get women who have lower respiratory tract infection and she has sepsis and she is preterm. So it is not necessary that just because the woman is pregnant and she has developed sepsis that she needs to be delivered to improve. Delivery is only indicated when the cause of sepsis is chorioamnitis, because that is when it is important that we evacuate the uterus as soon as possible. So decision to deliver the fetus, it should be individualized. Yes, resuscitation will improve the hemodynamic parameters and will improve the fetal perfusion. So for all you know, that once you have done her resuscitation and everything, maybe you can carry on a pregnancy till at least 34 weeks when the fetus is mature enough to survive. So delivery should be reserved for obstetric indications alone, and because there is no evidence that delivery is going to improve the outcome. Now, there can be several scenarios where a woman may need surgical procedures in order to improve. This can be evacuation of retained products of conception. If she has surgical site infection, then unless we debride, we will not be able to remove the source of infection. If she has any kind of an abscess or a pyoperitoneum, then we must drain the abscess or the pus. If she has pyelonephritis, then percutaneous nephrostomy can be done in order to remove the pus. If she has choriomnitis, then of course we need to deliver irrespective of what the gestation is. And a lot of times when we open the abdomen, we realize that a woman has pyoperitoneum and myometrial necrosis. So maybe in those cases, even hysterectomy is justified. So how much ever we do, where there are certain conditions where a woman will need to be transferred to the critical care, especially if she has needs an airway protection, she has pulmonary edema, ARDS, or despite her best measures, she still has hypotension, or she's developed renal failure, multi-organ failure, or her consciousness level is not improving. These are several indications where the patient needs to be transferred to a critical care unit for her better survival. Now, let us not forget about the babies. So whenever we think that she has choriomnitis and we are delivering her, or if she has any other features of infection and we are delivering the babies for obstetric indications, it is very important that we inform the pediatrician so that the babies also can be treated for sepsis. And because it is important for the pediatricians to know what is the organism for infection in the mothers, so they can give appropriate antibiotics to the neonates born. Group A, hemolytic streptococcus, it poses very high risk and can lead to a high neonatal mortality rate. So very important to keep the pediatricians in the loop whenever we are delivering the babies of mothers who have infections. So in the end, to summarize, this is the R1 bundle, which is sepsis 6, where we need to send for appropriate cultures, lactate measurements, start antimicrobials, and give the women fluid therapy, oxygen, and vasopressors. Once the patient is stabilized, do her physical examination and do the imaging studies as the need may be. Whatever the imaging studies suggest, try to get the source control as early as possible, because a woman will have a better chances of survival if the source is controlled as quickly as possible. If the fetus is alive, continue with the electronic fetal heart rate monitoring, give her steroids, allow the fetus to remain safe inside the womb if you think that you will be able to stabilize the maternal condition by appropriate measures. Ensure early enteral feeding, give DVT prophylaxis, because maybe she will come out of sepsis, but if we are not careful enough, she may develop postpartum deep venous thrombosis later on, which can pose major problem, and avoid hyperglycemia. So thank you so much. These were my references where I've used the Green Top guideline and the SMF consult series along with the maternal sepsis and septic shock published in the obstetrician and gynecologist. Thank you.
Yeah, that was wonderful, Dr. Smriti. I mean, sepsis is a part, all of us always say that, hypertension, hemorrhage, and sepsis, these are the three major killers of women. Hypertension and hemorrhage has been discussed very, very regularly in all the obstetric, clinical discussions, maybe, clinical meetings and such kinds of programs. But sepsis is the one which is quite rarely discussed. And that's the very reason, people are still scared of sepsis, because either they are totally not aware of what the complications of sepsis are. But once they see a case of septic shock, they're scared. So, they have a different extremes of reactions. So this is what is most needed, that, you have to diagnose sepsis at the earliest. You have to act fast. The 1 hour bundle, sepsis bundle, the SOFA score, everything is so important. I'm so thankful to you for making, this so extensive and exhaustive. I'm sure the attendees have been benefited to the max, and I hope they implement this in your day-to-day practice. So thank you so much, Dr. Smriti, once again for accepting our invitation and delivering excellent deliberation. Thank you so much, dear. Thank you. So over to you, Dr. Do we have the chairpersons? I think Dr. Shalini Tandon. She was
Dr.
here,
Shalini, ma'am.
Yes, it was really a very wonderful, comprehensive, and a very nice talk given by Dr. Smriti. I must congratulate her for that. And I'm very sure that all the audience were very much benefited by her talk. Thank you so much.
Thank you, ma'am.
Thank you. Thank you so much, Madam Shalini Tandon for accepting our invitation and of course accepting to collaborate with AMOGS and UPCOG. Thank you so much, Madam, for your gracious presence.
Thank you, ma'am, and
Please
wish
do
you all
bless
the
me,
best.
all of you.
Yeah,
Thank
all
you
the
so
best for your elections, Dr. Sneha. All the
Yes,
best.
madam.
And
Thank
all the
you.
best to Dr. Monica also.
Thank you, ma'am. Thank you so much.
Thank you.
Thank you for sharing this session, and thank you, Smriti ma'am, for an elaborative talk on obstetric sepsis. So our panelists would be more equipped with the next panel. So we move forward with the next academic session, that is hemorrhage in pregnancy. Our moderator is none other than Dr. Sneha Bhuyar madam herself, and we have expert Dr. Uma ma'am, the next Singh ma'am. She's a senior technical director of University of Manitoba. She's the ex-HOD, Dean of KG Medical University, Lucknow. And she's the WHO Fellow in Gynae Oncology, a Fellow in Indian Medical Education, President of the UP Chapter of Association of Gynae Oncologists of India, the Vice President of AGOI. We welcome you, ma'am, as an expert for this panel discussion. Our next expert is Dr. Uma Pandey, madam. She's a professor of the Department of OBGY of the Institute of Medical Sciences at Banaras Hindu University, the former head of the Department of the BHU, member of the Varanasi Society, and she is also an MRCOG Part 3 examiner, a DNB practical examiner, and the fellow representative of AICC RCOG North Zone from 21 to 23. We welcome you, ma'am. We now welcome our esteemed panelists for the panel discussion. The next slide, please, Saiti. Dr. Pratibha Chavan, madam, is the president of the Gadhinglaj OBGY Society. She is a consultant at Sant Gajanan Maharaj Rural Multi-Speciality Hospital at Mahagaon, which is a tertiary unit, including a cath lab and the radiation unit. Her special interests include Fothergill's operation and lap sling operations for prolapse. We welcome you, ma'am.
Thank you.
Our next panelist. Saiti, can we please change the slide? Yeah. Dr. Supriya Rudrapagul, ma'am. Madam is currently the secretary of the Gadhinglaj Society, and she has served as an honorary consultant at SDH Gadhinglaj. She has also delivered many talks on female health education and related questionnaires in schools and colleges. And she's currently working as a full-time practitioner at Bhavani Maternity and Surgical ICU as a laparoscopic surgeon. We welcome you, ma'am.
Thank you, ma'am.
Dr. Nageshwari Nanda is the General Secretary of the THANE OBGY Society. She was an MD gold medalist, and she has been the Managing Committee member of the THANE Society since 2019, and also the past chairperson of the Breast Committee of THANE OBGY Society. She is a consultant at Padma Shri Maternity and Nursing Home at the Wagle Estate, Thane. We welcome you, ma'am. Saiti, the next slide, please. Dr. Suchi Jain, madam, is a professor and the head of the department at Sevagram, Varda. She is also associated with the National Quality Control Programs, Lakshya, ICMR, WHO theory, and she's a postgraduate teacher and examiner at MUHS and DNB. She has been awarded the Dr. Praveen Mehta Fellowship Award in Endoscopy and the Movie Call Korean Award in the senior category in 2023. We welcome you, ma'am. Our next panelist is Dr. Vishwas Parulekar, sir. He is currently the secretary of the Navi Mumbai OBGY Society, the founder and medical director of Parulekar Hospital and Center for ART and Gynae Endoscopy. He has been practicing since the last 24 years. We welcome you, sir. Our next panelist is Dr. Supriya Jagtap. She is currently the secretary of the Udgir OBGY Society. Over to you, Sneha, ma'am.
Yes, thank you so much, Monica, for introducing all our panelists. I welcome everybody on board here. Without much ado, let us go straightway to the panel discussion. I can see Dr. Pratibha. I have already welcomed Dr. Supriya, Dr. Nageshwari, and Vishwas Parulekar. I could not see actually. So, did you check, Monica, whether the panelists have joined?
Ma'am, I am just trying to call them, ma'am.
I think there's some confusion regarding Dr. Shuchi Jain. So,
Yes, ma'am.
yes. So this is
Mhm.
actually from Maharashtra. He's from, yeah, Dr. Shuchi Jain is actually from Varanasi Society, right? So we have the
Yes, ma'am.
Dr. Uma Singh, Madam, and Dr. Uma Pandey. So welcome all my experts. And let us go ahead with the panel discussion. I hope you can see my slides. I'll just make it full screen. So let us go ahead with the practical discussion. We have this, so Pratibha, this is a first case for you. Primary gravida with 5 months pregnancy. She comes to you with history of bleeding per vaginum since morning and in the morning at home, and that is painless in nature without any cause. She was relaxing and it has stopped spontaneously also. So bleeding started spontaneously, stopped spontaneously. On further inquiry, she revealed history of spotting during early pregnancy as well. She, on examination, she is normotensive, non-anemic. Uterus is 20 week size, relaxed, fetal parts are well palpated, fetal heart is also heard. There is no bleeding PV at present. So what is your provisional diagnosis, Dr. Pratibha, and what further investigations you would like to do for this patient, and how would you take this pregnancy ahead? What is your management?
There could be a low-lying placenta, or there could be a placenta previa, or there could be a marginal separation of the placenta may be there. And
Right.
that's why there is bleeding. Routine investigations are needed, but for the final diagnosis, there is need for the sonography. And routine, along with the routine CBC and all pregnancy ANC profile, coagulation profile is also necessary to rule out any coagulopathies.
Right. Right, because we have to make sure that it's not only, we are not focusing on only the obstetric causes, but also some hematological because of the the coagulopathies, and of course there may be something what is called as indeterminate causes, where you have the cervical as well as vaginal causes, maybe the local polyp which is just bleeding, mimicking antepartum hemorrhage or early pregnancy hemorrhage for this patient. So you have said it all. All of us are doing this investigation. So Supriya, I would just ask you whether you go for, what is the role of prophylactic osteotomy for this patient? What is the role of tocolysis? And what special precautions to be advised for this woman so that she doesn't bleed it further, and it is, it helps you in taking this pregnancy ahead.
Actually, she is in second trimester. We should know what is the cause of her bleeding. And if it is if we will go for prophylactic osteotomy, and if she
No,
may.
once you diagnose low-lying placenta, Supriya Dr. Pratibha has already said that you need confirmation on ultrasound. So yes, now she doesn't have any other causes, hematological or indeterminate, but she has low-lying placenta. So now what is the role of prophylactic osteotomy? Should we or should we not?
We should not go for osteotomy, actually. We should go for tocolysis instead.
Perfect. That is the very clear message.
We should not touch to the
Should we go for
cervix or lower part of the uterus, because while doing the cervical encirclage, we may injure to the cervix. It's better to give her stick bed rest with tocolysis. And
Okay, let me clarify. Basically, we should not go for prophylactic osteotomy, right? This is a very clear message. So there is no question of touching the lower segment or placenta, to cause bleeding. So message has to be very clear, as you have initially said. Yes, there is no role of prophylactic osteotomy, because prophylactic osteotomy is either history recommended or history indicated, or it can be short cervix on ultrasound. Okay, only that. So here this doesn't fit into the criteria of prophylactic osteotomy. So that is very good point from your side. Now comes tocolysis. So tocolysis, whether she has uterine contractions, whether you want to stop her uterine contractions, or how. What is your take?
There are no contractions. That's why there is no need for
painless,
tocolysis.
no need of.
Perfect. So tocolysis also has no role, and as it is long term, because see, she is only 5 months. We have to take this pregnancy at least till maybe 37 weeks, preferably 37, 38. weeks, but if not, at least till 34 weeks. So, you know, long-term tocolysis is not as advisable. In fact, it leads to problems. And that is why here there is no indication for tocolysis and absolutely no for a long-term tocolysis. Now, what precautions you want to give this patient?
She should not do any strenuous work. She should be on strict bed rest. First thing, she should not have any
What else do
factor
you
which
want
contribute to
to
the straining, like
you
constipation,
know,
cough, or anything.
see that she
Uh,
will not bleed
yeah.
routinely? Anything else? I hope you can hear me. Is there any problem
No, it is
from my side?
interrupting.
My voice is breaking.
Yeah.
No history, no intercourse,
That
no
is what
lifting
I'm
of heavy weight.
right. No internal examination.
No
No
PV
interrupting.
examination.
Yes.
And that
No
should be
internal
strictly written on the
examination.
paper, as well as there is
Should not.
need to counsel her family members, and we should call the relatives and near one, and we should explain about the placental condition, so that they should take care of her. Actually, strict
Right.
bed rest is not necessary, but
Yes, that is what we're coming to. So it is not strict bed rest, but it is pelvic rest.
pelvic
So
rest.
Can say
pelvic rest,
pelvic.
that you have to, right? So it should be pelvic rest. So that, you know, she shouldn't stand for a long time. She shouldn't sit down on the ground. She shouldn't lift heavy weights, no intercourse. All these things should not strain at stool or, you know, all these things, you know, anything that raises her intra-abdominal pressure. Now, I would ask the experts whether they would like to add something to this discussion.
So,
Doctor?
yes, I would like to just add, very correct, very proper way of management you have suggested. It is
Yes,
just that
madam.
in case the patient is coming in acute phase of bleeding, hospitalization is a good idea. You
Yes.
know, and then you can keep for 3 to 5 days after the bleeding has stopped, discharge the woman with adequate counseling. And
Yes.
rest, I think I agree with all of you. A very good counseling is what is required, because this may be just first warning phase,
Perfect.
and the outcome may be preterm delivery and, you know, acute bleeding conditions. So counseling at this stage of the patient and her family, and preparedness for future kind of, you know, make sure that you are at least secondary or a tertiary level care. You can reach whenever there is an emergency.
Correct.
Those things have to be counseled for.
Right. Perfect. So, I mean, very nice inputs from Madam Uma Singh, and of course, Dr. Uma Pandey. Do we have something to be added here? Dr. Uma?
Yes, ma'am. The only thing we have to be frank enough with the
Yes,
with the
please go
couple,
ahead.
frank enough with the couple to stay away from the husband. Yeah, that is the most important thing. Apart from that, the patient has to be informed that this is a placenta, which most likely going to go up, and that way you will be fine. You might even have normal delivery. There's nothing to worry. But if not, then she should
Right.
also be told that she might have placenta previa perfecta, might need blood and cesareans.
Yes, so perfect. All of you have said it all. I'll just say that, you know, make a habit, you know, even as per the RCOG recommendation and as per our routine ultrasonography recommendations, every pregnancy should have at least, you know, 2 scans in the early pregnancy, 11 to 13 weeks, where it gives you an idea of low-lying gestational sac, and of course at between 18 to 20 weeks or 18 to 24 weeks, I would say, that where, you know, you see where the placenta is localized, and also you look for the presence or absence of the retroplacental zone. So once you have the low-lying placenta, you manage it as per the patient's location. If she is bleeding repeatedly, the best way is to hospitalize, as Madam Uma Singh has already said. If she is staying close to hospital, or she's closer to staying in a city where, the family understands what the treatment is. They are ready for, the blood and blood arrangements. And if at all she lands up into problem, they are easily access. The hospital is easily accessible. Then definitely you can treat them on domiciliary basis. But yes, you have to warn them that if at all she bleeds, she can bleed massively. And that is why they need to take care of all these things what you have discussed. So this patient actually had a low-lying placenta, and as per all your guidance, she has continued this pregnancy. Now, when should you plan her delivery and how you should go ahead with the management? Once again, we start from Dr. Pratibha.
Our aim is at
Pratibha,
least till 34
yeah.
weeks. That's why we have to
Yes.
push till 34 weeks.
Okay. And how do you prepare the fetus now? It's going to be
There
a
is need to give for the steroids as well as
Steroids,
magnesium
yeah.
sulfate for the nervous maturity.
neuroprotection.
Right.
Correct. Perfect. So you
And
prepare the fetus by giving magnesium sulfate. You all of you know the dosage schedule. We will not discuss, and the steroids also. Maybe methazone or dexamethasone 24 milligram over 24 hours. I'm sure all of you know that FOXI and IAP has a joint statement saying, even the NICE guidelines and all the Cochrane database say that any of the two steroids, 24 milligram over 24 hours, gives you equal effect for as far as the lung maturity is concerned, and there are no other side effects. What will be your mode of delivery?
cesarean section is the choice. And there should be senior gynecologist as well
Yes,
as we
yes.
have to call for the help, as well as preparation of the blood should be kept ready, previous arrangement, as well as
Yes,
proper
perfect.
counseling of the consent of the patient is necessary before taking for the
Yes,
section.
Even
Only
we should
one point
consult them
I would
about
like
the
to add.
obstetric hysterectomy if needed.
And if there is a past
Yeah.
spectrum
So
diagnosed by for the past spectrum,
yes,
again there is need about the proper counseling about the massive blood transfusion protocol,
perfect.
and obstetric
Perfect.
hysterectomy may be need, and the
Yes.
urologist as well as oncologist help may be
Yes.
needed.
Yes. So everything has been said. Only one point I would like to add. When you are trying to take this pregnancy, as Dr. Uma Pandey has already said, that there is a chance for migration. So in second, this is 5 months. So when the pregnancy goes beyond 30 weeks, 32 to 34 weeks. 32 weeks is the time where you once again confirm that yes, the placenta is still low lying and it is a major degree placenta previa. Then you have to go ahead with cesarean section only. If it has migrated, then maybe you can think of going for
Right.
vaginal, right? So I think that should be all. Madam, anything to be added? Okay, so let us go ahead with the second case now. We have this. Do we have Nageshwari here? I think no, I can't see Dr. Nageshwari. And anybody else? Sarita Tirke. I don't know whether the other panelists have joined. I think one who are present we can discuss. We have this second gravida paravan with 9 months amenorrhea, and she comes to you in labor. Pulse rate is 100, blood pressure is normal. There is no pallor, no edema. Uterus is full term contractions, 40 seconds every 3 minutes, and contour is well maintained. Head is fixed. Fetal heart is 140 per minute. The patient starts bearing down, and there is spontaneous rupture of membranes. With fresh gush of bleeding. There's sudden drop in fetal heart rate. What is your diagnosis and how will you manage? I think both of you have to discuss this once again.
Abruptio placenta may be there.
Placenta.
Okay, so see, once again, I just that can be one possibility if it happens during second stage, but the uterus is full term contractions are only 40 seconds to every 3
Another
minutes.
one possibility, there may be vasa previa may be there.
Perfect, perfect. You hit
Okay, next
because there is a fresh gush of blood is there.
Yeah. Because of uterine contraction, there may be some cervical factors. There may be rupture of a cervix, some laceration in the cervix, which give gush of bleeding also.
Yeah, but that will not lead to fetal distress.
No, it is
Sudden
a
drop in.
placental. It is bleeding from the placental side, which
Mm.
causes a drop in the fetal heart.
Okay, but then that will not happen so suddenly. Abruptio is accepted if at all it happens, in the second stage. But this is very classical that everything is normal. She's normotensive, okay? She's normotensive, okay? Usually it happens in hypertensive patients, but yes, there can be other reasons. So she's normotensive and she's having everything normal till now. Only when the membranes rupture, there is a fresh gush of bleeding and there is a fetal heart drop. This is very classical of ruptured vasa previa, right? So as it is, as you have said, abruptio placentae, rupture uterus and vasa previa, these are the differential diagnosis. But then yes, you are very sure when you see that fresh gush of bleeding and the sudden drop in fetal heart rate, when previously there is no scar on the uterus and there is no placenta low lying. So definitely it goes in favor of vasa previa. Now, how do you manage this patient, Dr. Pratibha?
There is simultaneous management of to call for the help and as well as to take the two IV lines and start the crystalloid solutions, arrange for the blood. Meanwhile, crystalloid solution as well as call the arrangement for the cesarean section because there is a fetal distress. And again, depending upon the status of the cervix and Bishop score, if the favorable, then only there is we can try for the normal labor.
Yeah, I will just pause you here. She is already progressing very well. She's bearing down.
Bearing down.
Right?
If,
Bearing down and she ruptures membranes now just about to deliver. Okay, so then what is the modality of management? What is?
Again,
If she will deliver early, it's okay. Otherwise, we will go for application of vacuum to deliver her as early as possible
Yes.
to ship the baby.
So what vasa previa actually, it is a very catastrophic event for the fetus, but mainly because it's the fetal blood which is going, so fetus has a blood volume of 300 ml and that is, if that is lost, then very severely the fetus gets affected. So here, you have to deliver the baby as fast as possible by whatever modality. So if you have the arrangement for go ahead. At the time, if the she is fully dilated, fully fixed, and membranes are up, that the delivery is imminent, go ahead with the instrumental deliveries, as you said, forceps or vacuum, whatever you are comfortable with, because the mortality associated with the vasa previa is very, very high. And even the morbidity, severe morbidity for the baby is very high. And that's a very reason we have to go ahead with the delivery as soon as possible. How do you have the high index of suspicion for such cases?
Yes.
By sonographically, we have to diagnose before only, no?
Yes.
The filamentous insertion of the placenta or traversing vessel above the internal os, we can diagnose by sonography. If the previous
Perfect.
diagnosis is ready, then
yes. So if you have a battledore or veramentous insertion, if you have a substantiate or low-lying placenta, that has migrated. So usually the vessels run across the internal os. So that is how you can have a high index of suspicion. And if at all you diagnose this immediately, don't allow this patient to go for
go in a labor.
spontaneous labor or
Electively, they can be
spontaneous.
taken for cesarean section.
Perfect. So, Madam Uma Singh and Madam Uma Pandey, do we have something to be added here? Dr. Uma?
Yes, ma'am. Sorry.
Please.
Not much, just that rather than one-twos, we would prefer forceps because forceps is faster, while one-twos takes time. So if it fulfills all the criteria, then yes, forceps. If it doesn't, then maybe otherwise forceps. And another thing is that you could do Doppler that has already been mentioned and identify the vessel. Perhaps you could also do a speculum examination and you will be able to see vessel traversing that if you haven't done the Doppler.
Right.
That is another possibility.
Perfect. So I think all our panelists are busy. Three of them have messaged me already. So I think this is the last case we discuss. Yeah, so we have this 32-year-old para 1 previous season. So this will be in continuation, the discussion. So male child, 1 year only. This is her first visit to you during 6 months. As her husband gets transferred to your city, so she comes to you in 6 months with history of bleeding. When you inquire further, she gives you history of spotting during early pregnancy. The ultrasound report initially says yes, the placenta is low lying. Now, when you do ultrasonography, there is again the placenta is low lying and there is retroplacental space is absent, or the retroplacental leg is absent. Anomaly scan is normal. So at 30 weeks, she again starts bleeding at home significantly. By the time she reaches hospital, it stops. What is your diagnosis and how would you tackle this patient? Pratibha, I have read your already that case I have read on AMOGS. You have managed such cases. So
Yeah,
please,
pass.
yes,
I managed 2 cases of pass this year by embolizing first vessel,
yes,
by keeping balloon and then embolizing after the cesarean section.
right.
And again here the diagnosis is very important thing, to look for the retroplacental area during the sonography, as well as lacunae in the placenta, dilated and irregular pattern of the vessels,
Yes.
that can important for the diagnosis of the pus spectrum. And
Mhm.
there is obvious bulging if there is only percreta, but normally this retroplacental space demarcation is gone. There is no need for MRI also if the sonography machine is good, and only for the posterior placenta there is need for the MRI to rule out any percreta spectrum.
Right, right.
And we are managing it because ours is a tertiary care center. Yeah,
Yes,
tomorrow also I planned one more case pass
correct.
section.
Perfect. So this patient is now only 30 weeks. So how do you conceal the patient and the relatives? And if at all she bleeds significantly, how do you talk? How do you conceal about the baby? When do you want to take her for? See, if she bleeds significantly, you have to take her for cesarean section and elective obstetric hysterectomy then and then only, right? So how do you conceal and
But
how do
for
you
this patient
prepare
now, she is
your?
only 30 weeks.
Yes.
I will push till the 34 weeks at least. Usually,
Ah,
past spectrum, they are 34 to 35 weeks is enough for them.
yes.
And till I have now time for the 4 weeks or till she bleeds. Now, we'll
Right.
prepare by giving steroids as well as by neuroprotection. And counseling of the relatives is very important thing. And there is need for the tertiary care center always. If the patient is from the periphery, we have to explain them about the tertiary care. There is need for the arrangement for the blood, as well as onco person, neuro person should be ready, neonatologist, pediatrician team, anesthetist, proper experienced personality should be there, and need for the hysterectomy may be there, or there may be patchy resection of the placental resection may be possible.
Right.
This three P's
Yes.
I performing. My drum is also containing satin sky clamp. And this Euro clamps, they are very helpful, I feel. From the cornu till the down, they easily snugly fits towards both the sides, and that requires only few seconds to apply them. As well as two simple arteries can simplify our IP ligament and vessels. As well as Ashokanand stitch is also helpful for the descending cervical vessels. And this triple pre procedure also we can able to save the uterus. And I saved uterus in 2 patients this year.
Perfect, perfect. That is very, very important. But then suppose you have already talked about the precautions and what team you need. How do you take the abdominal incision? This is for just discussion for our attendees also. Which incision do you prefer and which incision on abdomen and uterus?
On the abdomen, vertical incision
Vertical
is
incision.
easily accessible, and
Mhm.
on the uterus, by localization of the placenta,
Yeah.
depending upon the placental location, just not include the placenta, above the placenta, it could be
Yes.
transfundal, or
Yes.
it could be vertical,
Vertical.
above the placenta.
So vertical, just short of the placenta, just
Placenta.
stopping just short of the placenta. No, at no point of time it should incise or even reach the placenta, right?
Even these previous 2 or 3 LACS are there. Paramedian incision on the abdomen also works very well,
In fact,
because midline adhesions are so many are there,
yes,
and
and
to separate them it's difficult.
Perfect. Because midline incision is difficult to extend also. You have to go along the umbilicus. So, surgeons prefer right paramedian more, and that gives you lots of access. If at all you feel, so much of manipulation to be done. So definitely a right paramedian incision is better than the midline vertical. And uterine incision you have already said, but then yes, absolutely no attempt to separate the placenta.
Yes.
If the diagnosis is wrong, some people say diagnosis may be wrong. If it is wrong, it will come out spontaneously, right? But absolutely no attempt to separate from our side, because that will bleed torrentially and the stable patient will become unstable, right? So definitely, if you have taken consent for hysterectomy, informed written consent, well ahead, go ahead with the hysterectomy before the patient becomes unstable. So early hysterectomy saves life. But if at all you have the facilities, as you have already talked about, and if the patient is not at all willing for hysterectomy, and if she is stable hemodynamically, and you have arrangement for lots of blood and blood products, you can go ahead with the uterine saving surgery for this placenta accreta spectrum. Anything from your side, Dr. Uma?
No, ma'am, most of the things have been covered very well by Dr. Pratibha, very well. Only thing is that if woman is not actively bleeding, maybe we should also think that the ICU facilities in the hospital, if at all,
yes,
if possible, and also there could be a coagulation defect for these kind of patients. So we should be ready with that as well, not only blood. The massive blood bleeding leads to coagulation defect.
yes.
And last thing, you have already mentioned it, Dr. Sneha, but I'm going to mention it again. And do not just do nochectomy of the placenta. Don't do that. Don't pull the pieces of placenta, because that makes the situation even worse.
Yes.
That's all. That's
Yes.
all. Thank you so much. It was
Thank you
wonderful,
so
Dr.
much.
Pratibha.
Yes.
Wonderful.
Thank you, madam.
Thank you so much,
Thank you.
dear Dr. Pratibha and Supriya. That was wonderful input from your side. Thank you so much, Madam Uma Singh and Madam Uma Pandey, for being the excellent experts. And of course, your experience and expertise definitely counts. Thank you so much for gracing the program as well. I thank all of you once again, and just make a humble appeal to please vote for me. And yes, thank you so much. Please vote for me and support me from wherever possible. Share my flyer or message, your personal message, to all your friends, colleagues, and alumni. With your support, I wish to work for Foxy and all of you. Thank you so much.
Thank you,
ma'am.
Sneha,
Bye.
madam. We are with you. All the best, madam. We are with you. This time you are sure you are be there.
Thank you, madam.
Thank you,
Best
everyone.
wishes.
Thank you all
Best
the best.
wishes, Sneha.
Madam.
And it would be a pleasure to see you on that seat.
Thank you, madam. Means a lot.
Yes, ma'am.
Also,
Definitely.
best wishes for Dr. Uma Pandey and best wishes for Dr. Monica Umberdan.
Monica madam also.
Dr. Bharti Maheshwari, we have already wished. So best wishes to Bharti once again. Thank you, Madam Uma.
Best wishes, Uma madam and Monica madam also.
Thank
Sneha
you.
madam, all the best.
Thank you.
Thank you.
All the best to you all.
Thank you.
Thank you and good night, everyone.
Thank you and good night.
Good night. Good night.
night.
All of
Good
you,
night.
please spread the message and get maximum.
Sure, ma'am. Sure, ma'am.
Yes, madam, sure.
Thank you.
Pakka.
Thank you.
Pakka. Bye, ma'am. Bye.
Bye. Bye. Hello. Thank you, Dr. Pratibha and Supriya. स्पेशल थँक्स टू बोथ ऑफ यू. आज गडबडीने आज मी खूप ट्रॅव्हलमध्ये आहे ना, तर खूप फारसं कोणाशी बोलणं नाही झालं, नाही तर प्रोग्राम्स इतके फुल असतात. पण आजचा हा शेवटचा प्रोग्राम आहे आणि UPCOGला इनॉग्रेशनला सगळे जॉईन झाले, ते खूप छान झालं. मला वाटतं पॅनलिस्ट आता हे थोडंसं इमर्जन्सीमुळे जॉईन नाही होऊ शकले, अदरवाईज 8-8, 10-10 पॅनलिस्ट असतात, जम्बो पॅनल.
त्यामुळे आज आम्ही जास्त बोललो.
छान झालं ना. गुड गुड. अँड यू आर द राईट
एक्सपिरियन्स झालाय.
बिलकुल बिलकुल. थँक्यू सो मच अँड प्लीज टेक केअर ऑफ मी. ओके.
हो मॅडम.
थँक्यू सो मच. थँक्यू. बाय बाय
बाय मॅडम.
बाय.